I am here to present the case of 9 months old female child who hails from Kodibag, Karwar, Hindu by religion, and belongs to socio-economic status of lower middle class according to modified Kuppuswamy scale. The informant in this case is mother and she is reliable. The educational status of mother is second PUC. The birth order of child is first child born out of non-consanguineous marriage. So the child basically came with chief complaints of cough since 3 days, hurried breathing associated with grunting since 3 days. Child was apparently all right 3 days ago, then she developed cough. Cough was insidious in onset, non-progressive, was hoarse hacking type in character, no diurnal and postural variation. There was no aggravating and relieving factor associated with it, and there's no episodes of vomiting after bouts of cough. Coming to the history of hurried breathing, there's also a history of increase in pace of breathing of child with chest indrawing since 3 days. Hurried breathing was present since 1 month age, but presently increased in severity and was associated with grunting. She also complains of inability of baby to suckle for long time in one go, and the baby takes rest intermittently from past 7 months. That is suck, rest, suck cycle is present. Baby has profuse sweating, especially on forehead, since past 7 months noticed while feeding. There's also a history of baby not gaining weight in last 6 months, history of noisy breathing, and also history of recurrent hospitalization for similar complaints in past at 1 month, 3 months, and 6 months of age. There's no history of swelling of limbs or abdomen or decreased urine output. No history of bluish discoloration of lips, mucous membrane, toes, or extremities. No history of syncope or transient loss of consciousness. Coming to past history, there is history of similar complaints on 1st, 3rd, and 5th month of age for which child sought hospitalization. No history of blood transfusion and no surgeries are done in past. The child is first child, booked case, detected by urine pregnancy test at 2nd month of amenorrhea and was confirmed by ultrasonography. In first trimester, there is no complaints of fever with vesicular eruptions or any teratogenic drug or radiation exposure. Regular ANC visits were undertaken, folic acid was taken. In 2nd trimester, quickening was felt at 5.5 months of gestation. Regular ANC visits were done, and there is no history of any complaints suggestive of pregnancy-induced hypertension or gestational diabetes mellitus. Coming to 3rd trimester, the mother continued to perceive fetal movements. Regular ANC visits were undertaken. History of oligohydramnios was there, which was detected at 7 months of pregnancy. No history of any complaints suggestive of gestational diabetes mellitus or pregnancy-induced hypertension. Natal history. Child was delivered 1 week before expected date of delivery, that is around 9 months of gestation, by lower segment cesarean section in view of oligohydramnios. Baby cried immediately after birth. Birth weight was 2.4 kilograms. BCG, OPV, hepatitis B, and vitamin K was given. Breastfeeding initiated within 24 hours after birth, and there is no history of any NICU admission. Neonatal history. The baby passed urine and meconium within 24 hours of birth. No prelacteal feeds, exclusively breastfed, and baby used to sleep 2 to 3 hours after feeding. No history of syncope or convulsions within first 24 hours of life. She was admitted at 1st month of life with chief complaints of cough and hurried breathing, upon auscultation for which abnormal heart sounds were detected, so referred to higher center. Coming to diet history of the child, in first 6 months, the baby was exclusively breastfed, fed on demand, and it took a lot of time for the child to feed because as the child could not suckle for long. Complementary feeds were started at 6 months of age with rice, kanji, and dal water. Cow milk was also started but given in 1:3 dilution. No fruits or smashed vegetables were given. Breastfed is also continued on demand. So this is the diet history of past 24 hours of complementary feeds based on 24 hours recall method. So in morning, the food item consumed was rice kanji and ghee, 1 cup of rice kanji and 1 tablespoon of ghee, calories corresponding to 150 kilocalories and protein corresponding to 1.5 grams. Afternoon, dal water was given 2 cups, calorie intake 110 kilocalories and protein intake 5 grams. In dinner, cow milk 1:3 dilution, 1 cup, 67 kilocalories, protein intake 1.1 grams. Total calorie consumed comes out to be 282 kilocalories, and the calories required for this age group is 880 kilocalories per day. The calorie deficit is 598 kilocalories, which corresponds to 67.9%. The total protein consumed was 7.6 grams. Protein required was 14.4 grams. And the deficit was 6.8 grams for that, which corresponds to 47.2%. So based on the diet history, the impression I got was the complementary food was started at correct time, but was not followed in a proper manner. And the diet was also deficit in calories and protein, which could be the cause of poor weight gain by the child, as stated by the mother. Coming to developmental history, so the development of child was assessed in 4 domains: gross motor, fine motor, social, and language. In gross motor domain, the milestone achieved was rollover. The expected age of attainment for the milestone is 5 months, but in this case, this milestone was achieved at 9 months of age. And for this development question comes to be 55%. For fine motor, the milestone achieved is unidextrous reach, that is reaching an object with one hand. Expected age of attainment was 6 months, and observed age here is 9 months. Development question comes to be 66%. Social, milestone achieved is parental anxiety. Expected age is 6 months. Observed age is 9 months. 66% development question. Language, monosyllables like use of ma, pa, ba, not by syllables are still not attained. So expected age of attainment of this was 6 months and observed age is 9 months. Development question comes to 66%. So overall development question upon calculating all the 4 domains comes to 63.25%. And as it is less than 75%, the impression we get is global development delay. Coming to immunization history, at birth, BCG, OPV 0 dose and hepatitis B birth dose was given. At 6, 10, 14 weeks, OPV first, second, third dose was given. Pentavalent vaccine first, second, third dose. Fractional IPV 6, 14 dose. Rotavirus vaccine was given at 6 and 14 weeks of age. And the vaccines for 9 months of age is still not given. When I asked the reason for it, they said the weight of the baby is not appropriate for the immunization of 9 months of age. So the baby in this case is not immunized up to date. Coming to family history, mother is housewife, father is coolie. Both mother and father are literate. Child is born out of non-consanguineous marriage with mother's age at time of birth 25 years and father's age 28 years respectively. There's no history of similar complaints in parents or any other family members. No history of asthma, TB, allergy in family. The first degree pedigree is shown here for the childbirth. Environmental history, they reside in Pakka house with 3 rooms, 3-generation family, 6 people, adequate ventilation, municipal water supply, sanitary latrines, and they use LPG gas cylinder for cooking. There's no history of bottle feeding, and there's no history of any member smoking in the house or use of chulha for cooking, and there is no seepage of water. So the summary, a 9-month-old girl born out of non-consanguineous marriage, birth order 1, delivered at 9 months of gestation by elective lower segmental cesarean section due to oligohydramnios, belonging to lower middle class according to modified Kupus-Former scale, presents with coughs, which is hoarse hacking type in character, associated with hurried breathing, with chest retractions since 3 days, with history of recurrent hospitalization in past for similar complaints, not associated with any cyanotic spells. Suck cycle is present, associated with profuse sweating over forehead while feeding and inability to gain weight from past 7 months. The diet is deficient 67.9% in calories and protein 47.2%. Global developmental delay is there and the child is not immunized up to date. So based upon the history findings, I come to the provisional diagnosis of cyanotic congenital heart disease associated with large left to right shunt.
Anjali, Anjali, I'm going to stop you here. Can you hear me?
Yes, sir. Yes, sir.
Okay. So good presentation so far. You went into the history. Some rapid points. Number 1 is avoid using the word case.
Okay.
This is your patient who is a child or an infant. Do not use the word case. You tend to repeatedly use the word case. It's a very common error, and sometimes we don't like that because it is depersonalizing the child. Second statement. When you look at your presenting complaint, you have gone typically by saying, why did you come here? 3 days of cough, fast breathing, grunting. But then you continue in the history of presenting complaint to tell me for the past 6 to 7 months, the baby has been having suck rest suck cycle, has been having sweating, has not grown properly, has had difficulty in feeding. And you also went on to tell me that at 1 month, 3 months, and 6 months, the child got admitted with recurrent, what appears to be lower respiratory tract infections. You also told me in the history of presenting complaint that the child had a murmur detected and told to the family at 1 month of age. All I'm trying to say is, if all this is in your history, then it is not wrong for you to change your presenting complaint. Can you imagine if I said presenting complaint, this 9-month girl child presented from 1 month of age with suck rest suck cycle due to difficult feeding, excessive sweating, failure to gain weight, and was told to have a murmur at 1 month of age. Presently, the child has had 3 days of cough with fast breathing. If you look at that presenting complaint, you have already cracked the diagnosis. But when I look at your presenting complaint, 3-day history of cough, fast breathing, I'm thinking of a simple lower respiratory tract infection or a pneumonia. So you are a clever girl. Use your history of presenting complaint to strengthen your presenting complaint so that when you present, it is more logical. When you look at this baby, 9 months old, I do not know what is past. There's hardly any past for this baby. So you've got all the good points in your history. You could have inculcated it in your presenting complaint in chronological order, because the opening statement of history of presenting complaint is number 1. Presenting complaint XYZ. History of presenting complaint. The child was apparently well till. That decides the presenting complaint. So Anjali, tell me, at the end of when you came to the history of presenting complaint, if I ask you to start the line by the child was apparently well till, what would you say?
The child was apparently all right till 1 month of age.
Finished. So that everything becomes relevant and becomes a presenting complaint. Do you understand? So don't take it to rigidity. Don't be rigid that no, why did he come here? Actually, he came to your hospital because the bus stopped there at Karwar, did not continue to Goa. Now, you're not going to write bus stop, therefore the child came to us. So use your history of presenting complaint to make your presenting complaint more conclusive, because the opening statement is, my child was apparently well till XYZ. When the child developed fast breathing, cough, was told to have a murmur, following which for the past 6 to 7 months, suck, rest, suck cycle, excessive sweating, and failure to gain weight. Next point. You use the word syncope at least 3 times. Now, syncope is basically for you and for me is fainting, correct? Now, I do not know whether a 9-month-old baby is going to faint. So you use the word loss of sensorium, that's okay. But I think you should not be harping on syncope. Syncope is predominantly for aortic stenosis, for example, in a cardiac lesion, seen in older people. But I do not know whether syncope is a common symptom in infant, unless you have another argument. What did you have in mind when you said syncope?
Sir, what I felt was, as we are probably thinking of cardiac pathology, so maybe due to inadequate blood supply to brain, the baby can have altered sensorium or transient loss of consciousness, or also due to hypoxia.
So little unusual, no? So it will be shock, arrhythmia, aortic stenosis causing syncope. It's not a common presentation. unless you had a hypercyanotic spell and the child in a cyanotic heart disease and the child became unconscious. So avoid the word syncope when you're talking about this particular infant because of the age.
Sure.
In the ultrasound details, you mentioned that antenatally it was confirmed by ultrasound, the pregnancy, correct?
Yes, sir.
Now there it is really worth mentioning, was any cardiac abnormality detected on ultrasound, on fetal ultrasound? Okay. So it is unlikely, but when you talk about antenatal ultrasound for pregnancy, it is also worth asking the mother, did they say there was anything wrong with the kidney, the heart of the baby, or the brain of the baby, which is that fetal anomaly scan done during antenatal period. In the first trimester, you said there's no fever with vesicular eruptions.
Mm.
Why did you ask for fever with vesicular eruptions in the first trimester?
So to rule out torch infections because these
Which
are
torch infection has vesicular?
rubella. Rubella.
Vesicular. Anjali, you're running into trouble.
Yes.
So rubella is German measles, very similar to measles. When you said vesicular, for me, I can only think of chickenpox.
Chickenpox.
Now, chickenpox causing cardiac. So I'm wondering, was it a routine question or was it a targeted question? I would have liked it to be a targeted question. So there is no issue of fever and rash, but I would not say vesicular eruption specifically. Agreed?
Yes, sir. Agreed.
Because vesicular fever strongly indicates chickenpox, which is more dangerous, especially perinatal event. Okay, it can also cause problems in the first trimester, but not really cardiac. Cardiac, I'm thinking of what viruses, which torch infection am I looking at when I'm thinking of a cardiac problem?
Torch, rubella we will see, sir.
Rubella.
Then plasma.
Okay, so be very specific. CMV, less likely. Toxoplasmosis, less likely. Herpes, less likely. Syphilis, HIV, less likely. So it is only rubella which you are really interested in, unless it was a general, full clearance sale, everything you're asking, hoping that something's right. If you're targeting because your history is suggestive of cardiac problem, then I would have enjoyed listening to there is no issue of fever and rash suggestive of rubella. Okay, so that's what I wanted to know. Then you mentioned about oligohydramnios. Of course, you will be asked about the causes of oligohydramnios. Would you like to tell us a few causes of oligohydramnios?
Pregnancy-induced hypertension also leads to oligohydramnios. Then
okay, you need to list, you need to classify it into maternal causes, placental causes, as well as fetal causes. Okay, so that homework I'll leave that because of time. Now coming to your calorie count.
Yes, sir.
I presume your baby is still breastfeeding. Is that correct?
Yes, sir.
Nowhere in your table did you write breast milk and how many calories the baby is getting.
So because we couldn't assess how much the baby is able to feed because she was not feeding very appropriately. When I saw while breastfeeding.
Anjali, baby is getting breast milk.
Yes, sir.
You should have had breast milk because you're giving me a ridiculous kilocalories of 282. So, in other words, how do you calculate calories of breast milk in a breastfeeding baby? That is my question actually.
Based upon how many times mother feeds the baby?
No. Now, what is the normal weight approximately of a 3-month-old baby, 6-month-old baby, 1-year-old baby? Approximate weight.
See, at 3 months of age, it will be.
Let's say 3 kilograms at birth.
So at 6 months of age, the weight doubles.
Okay, so 6 kgs at 5 months. and 9 to 10 kgs at 1 year, correct?
Yes.
Now the cheating method is, I need enough breast milk to survive at birth. So therefore, within 2 weeks of birth, my milk supply will be approximately 400 ml per day. A normal mother will produce 400 ml per day. By 5 months, when the weight is expected to double due to exclusive breastfeeding, the baby at 5 months should get from the mother normal production equal to sustained 6 kilograms. So roughly 700 to 800 ml of milk. After that, it maintains at 700 to 800 ml of milk. And that is why we need to supplement with complementary feeds. So the next time you calculate for 9 months, you write breastfeeding, estimate quantity 800 ml, 800 ml multiplied by 67 kilocalories per 100 ml, and add that to your calorie count. Are you all clear about that?
Yes, yes.
So don't ignore my breast milk. The breast milk is also part of the calorie count. Then you'll find your deficit little less.
Yes.
Then I was very upset. Anjali, you said mother not following, not properly feeding the baby. My baby has got heart failure, suck cycle. You're blaming my mother saying, no, not following properly, not properly feeding. Okay, so be careful of those words. Faulty feeding, not properly. It has nothing to do with that. This mother tried to feed, but the baby's condition did not allow. You came to development. Yes. Did you do a DDST?
Developmental skill assessment.
Then, okay. So from now on, because you're a PG in pediatrics,
UG, sir.
Pick up you're a UG. Oh my God, yes. Sorry. Okay. So that's good. You did a development using the table. I'm happy with that. Quietly have a look at DDST. It gives you an impression in future whether you can use it. But certainly I'm very happy that you did not use it as an undergraduate, but no harm in knowing about DDST. Yes. Okay. The reason why I'm saying that is, I expect this baby. Do you expect the baby to have global development delay, or do you expect it to be very specific? Heart condition.
As the developmental delay was expected in this baby, sir, because of the baby is not feeding the nutrition is also not adequate. Like baby is not feeding well due to suck cycle, and heart defect is there that will be again contributing to hypoxia and all.
Agree. So I think I agree with you. I expect it to have motor delay predominantly. No muscle mass, unable to sit, unable to stand. Okay. I do not expect it to have social and fine motor and language delay, except for the socioeconomic group, coolie working parents. So I just wanted to bring that out. Immunization. You did not specifically tell me about pneumococcal conjugated vaccine, which is part of the government program now.
Yes, it was not taken by the mother. I saw the thigh card.
I want to hear that because it is important in a heart condition when the child is getting recurrent respiratory infections. Second vaccine in a richer patient would have been influenza vaccine. In a richer patient, not in the, I would not make this patient guilty, but influenza pneumococcal becomes important in a child who has got a heart condition to protect against recurrent infections. In the family history, you told me no family history of baldness, no family history of diabetes, no family history of tall people, no family history of short people. You never told me family history of heart disease.
Similar complaints.
Similar. Nice try. No similar complaints. You specifically tell me there is no family history of heart disease in the parents, and if there was a sibling. Because if the sibling has got heart disease or the parent has got a congenital heart disease, the risk is increased for the next baby. Okay. Finally, in your diagnosis, you said acyanotic congenital heart disease, large left to right shunt, very impressed. You did not mention about growth failure. You missed that in this provisional diagnosis. You did not mention about your development delay. You did not mention about missed immunization. And why has the baby got suck rest suck cycle?
Sir,
Sweating.
because breastfeeding is itself is an exercise for the baby, and here due to inability of the heart to pump adequately.
What is wrong with the heart?
Ventricular septal defect is there, sir.
What is wrong with the heart? Why am I not able to feed? Why am I not gaining weight? Why am I sweating?
Cardiac failure.
Thank you very much. So from your history, it's acyanotic congenital heart disease associated with left to right shunt, probably a large shunt, with evidence, with history suggestive of heart failure, with development delay, missed immunizations, and calorie deficits. Agreed?
Yes,
No harm in saying that. Okay. Go to your examination, please.
Okay, so I'll rectify. Thank you so much for correction, sir. Coming to general physical examination, child is conscious but not playful. Examine in adequate lighting and exposure after obtaining mother's consent while the child is lying on mother's lap. Pala was present, no icterus, clubbing, cyanosis, lymphadenopathy or edema C. So Pala was present only in lower palpebral conjunctiva. Normal skin color, pink lips and mucosa, normal finger and toes, no bluish tinge. Vitals, pulse was 112 beats per minute, regular rhythm, normal pressure and volume, measured in supine position in right brachial artery, bilaterally symmetrical. Temperature was 97 degrees Fahrenheit, oxygen saturation was 97%, respiratory rate was 53 cycles per minute, blood pressure could not be measured due to unavailability of appropriate sized cuff. Coming to anthropometry, the observed weight of the child is 4.1 kilograms, expected median as per WHO charts is 7.9 kilograms. So the weight lies below -3 standard deviation. Height observed was 63 centimeters. Expected median was 67.3 centimeters. Height lies between -1 standard deviation to -2 standard deviation. Head circumference observed was 41.5 centimeters. Expected median was 43.8 centimeters. And head circumference also lies between -1 standard deviation to -2 standard deviation. Chest circumference was 37.5 centimeters. And as the child is above 6 months of age, so we can use mid upper arm circumference. Mid upper arm circumference was 10 centimeters. Expected median in this in 9 months age group for a girl child is 14 centimeters. And the mid upper arm circumference lies between 2 standard deviation to 3 standard deviation. So based upon the anthropometry values, I come to an impression that the child is having severe acute malnutrition. First of all, the weight is below -3 standard deviation and the mid upper arm circumference is below 11.5 centimeter, which makes me think about severe acute malnutrition. Coming to head to toe examination, skull was normal, anterior fontanelle palpable with dimension 2 into 2 centimeter, not fused. Posterior fontanelle was fused. Hair black, no color changes. Eyes paler was present in lower palpebral conjunctiva. No icterus, KF rings, bite spot, dryness. Ear, no discharge seen. Nose, nasal flaring was seen with no septal deviation. Lips, no cleft lip, no cyanosis. Oral mucosa appears to be normal. Tongue, also no cyanosis, appears to be normal. Palate, no cleft palate. Teeth, normal dentition is present. Neck, normal. Nails, no clubbing. Skin, no skin lesions were seen. Abdominal genitalia appears to be normal. Spine and back appears to be normal. Lower limb, normal. No edema, lymphadenopathy. Coming to systemic examination, the system which I would like to examine first is cardiovascular system. Upon inspection, the chest wall appears...
Anjali,
yes,
sorry, can you go back one slide? I'll just finish the general examination and anthropometry, then we'll go to cardiovascular. Okay.
Okay.
So you use the word pallor plus present. Okay. Why did you look for pallor and what's your conclusion?
So as in nutrition also, the nutritionally child was deficit, sir. So, and the child, upon observing also, the child was appearing to be malnourished. So pallor we were looking for to see for any if anemia, if any it is present.
You think
And
pallor is related to anemia and probably nutrition. Agreed? Okay, good. Why did you specifically look for lymph nodes in this child?
lymph
A
nodes.
9-month-old baby, you're thinking of a heart disease. Why did you tell me about lymph nodes? What is the significance of lymph nodes in heart
Any
disease?
sorry, any overlying infection, like sometimes overlying infection, like so here also the child is having pneumonia. Due to that infection also lymph nodes can be engorged, or any, like basically to rule out any infection or other etiologies possible.
Anjali, what I'm trying to say is, what you tell me should be relevant to your patient building up. The idea of history is to crack a diagnosis. Then you use your examination to further crack your diagnosis. So maybe you did lymph node as a routine, but I'm not excited about listening to that in this particular child who's 9 months old. You said no edema seen. Where did you look for edema?
Edema, so here the child is not mobile. Here the child is sitting, so we'll look for sacral edema. So.
Yeah. So remember, a small baby less than 6 to 9 months is unlikely to present with edema, though it is going to be in failure. So yes, you will look for swelling of the feet because bilateral pitting pedal edema because of SAM. You'll also look for it in heart failure, but you're not excited because you will not, it's unlikely to be present. Only in rare cases will you see edema in a heart failure. Next slide, please. Okay, so here, ideally speaking, there's no way you can not give me a BP when you're suspecting a baby who's got a heart problem. Second point, if you take BP in a child who's suspected heart disease, you must take BP in at least 2 limbs, upper limbs or one upper and one lower limb when you're suspecting a heart failure. What is also important is all pulses were equally felt because coarctation of the aorta. So when you wrote the pulses, I did not remember hearing you saying all peripheral pulses were felt. Correct?
Yes, sir.
Respiratory rate 53 per minute is very high because it's a 9-month-old baby. Maybe you should have added, are there chest retractions? Do you remember the IMNCI?
Guideline for pneumonia diagnosis.
Yeah, so you should have mentioned tachypnea, but immediately have mentioned, is there subcostal or intercostal retractions? Okay.
Okay.
Next slide, please. Okay. Now, excellent tabulation. What is the current measurement? What is the expected measurement? And your comment. One suggestion is be mentally prepared to rattle off at the end of anthropometry the WHO classification, which you have mentioned, severe acute malnutrition. Also consider telling me the IAP classification, the Wellcome Trust classification, and whether you think this is an acute, chronic, or acute on chronic malnutrition. Do you understand, Anjali? So remember, in your OP guide and your standard textbook, you've got different classifications. WHO is excellent, but be mentally prepared for all children under 5 years to give me WHO interpretation, IAP classification, Wellcome Trust classification, acute, chronic, acute on chronic. Okay? Next slide, please. Now, I have noticed for many years now, a lot of you all are presenting head to toe, head to toe, head to toe. Okay, I personally, I am not in favor of head to toe because I'm not sure why you're telling me about the hair, why you're telling me about the root of the hair, why you're telling me about the eye next, why earnest. So head to toe is meant for you to remember to cover everything. Use the word general examination and then start rattling off what you want, because the head to toe examination, this terminology is a relatively new terminology and it doesn't really it's little upsetting because you are chumma telling me from head to toe. You are not telling me what, you're not looking for what is relevant. For example, look at your eyes. Pallor present, is it relevant?
Yes, sir. Need to do it.
Agreed. Ictris, is it relevant?
No, sir.
I'm suspecting a heart disease. Is ictris relevant to specifically tell me that?
No, sir. Not.
May or may not be. You can always argue with me and say heart failure can cause jaundice. Now look at the third thing. You said KF ring. Why did you tell me KF ring? It is seen in what condition?
It's not relevant in this case.
It is seen in Wilson's disease.
Wilson's disease.
Okay. Wilson's disease usually never presents before 3 years of age. Okay. Here you're building up a case of heart and you're telling me about KF ring. So that's why I'm a little allergic to this. White hot spots, you can always argue malnutrition, vitamin A. Totally agreed. Okay, quickly, in the oral cavity, in an older child, always mention about teeth. In a cardiac problem, always tell me about the state of the teeth.
Teeth I
Not so,
mentioned.
it may not be mentioned here because it's a 9-month-old baby.
No, teeth it was not that normal. Like 9 months, what?
Be careful.
Teeth, like, not all teeth were present, one or two.
Okay, so you must, so in a cardiac condition, always mention about teeth because it's strongly likely to be the source of infective endocarditis. Okay, carries teeth. Okay, quickly go to CVS.
Coming to cardiovascular system examination, upon inspection, the chest appears elliptical with no deformity, hyperdynamic precordium. Apical impulse could not be appreciated. Neither engorged JVP or neckness could be appreciated. Hyperdynamic carotid pulsations was seen. Palpation, normal temperature. Apical impulse was felt at fourth intercostal space, left to midclavicular line. Parasternal heave appreciated along left sternal border. Palpable thrills in systolic phase in third and fourth intercostal space. Percussion could not be performed. Coming to auscultation, S1 and S2 was heard. S1 was prominent at apex of heart and S2 at pulmonary area associated with grade 4 loud, harsh pansystolic murmur in third and fourth intercostal space and left parasternal border, and soft, short systolic murmur in second left intercostal space and mid diastolic murmur in mitral area. Coming to respiratory system examination, upper respiratory tract, normal septum, nasal flaring was seen. Oropharynx appears to be normal, no tonsillar enlargement. Lower respiratory tract, inspection appears elliptical in shape, symmetrical on both sides with intercostal and subcostal retractions associated with breathing. Trachea appears to be central. Apex pit not visible, no dilated veins on chest. Palpation, no local rise of temperature or crepitus, central position of trachea, apical impulse, fourth intercostal space, midclavicular line, decreased chest expansion on both sides, and tactile vocal primitus could not be elicited. Upon auscultation, vesicular breath sounds associated with rhonchi heard in all lung fields. Other system examination, per abdomen examination, no organomegaly, bowel sounds heard upon auscultation. CNS examination, normal tone of upper and lower limb, normal deep tendon reflexes, and no focal neurological deficit present. So based up, so let's stop, sir.
Continue.
Based upon history and examination findings, I come to the diagnosis of a 9-month-old female child suffering from a cyanotic congenital heart disease, situs solitus, most probably ventricular septal defect associated with large left to right shunt, with increased pulmonary blood flow and secondary severe acute malnutrition with no features of infective endocarditis, having an acute lower respiratory tract infection.
Okay. So Anjali, quick things. One is your apex. You did not describe the characteristic of the apex. You told me fourth intercostal space, lateral to the midclavicular line, correct? What is the character? Normal apex?
It was normal, sir. It was not diffusely present or.
Was it a forceful apex? Was it a heaving apex? Was it a tapping apex?
Tapping only, sir. Forever.
Okay. So remember, when you talk about the apex, you must tell me the character of the apex. So heaving apex is classically seen in systemic hypertension or aortic stenosis or coarctation of the aorta, where the finger will be lifted, kept up for some time, then come down, sustained up and then come down. That is called a heaving apex. The forceful apex, which I think may be present here if you go back and see your child, it lifts your finger and brings it down, lifts your finger, brings it down. So apex, which lifts the finger and brings it down, is a forceful apex. So I tend to stick to few words: heaving apex, forceful apex. Some people call it the hyperdynamic apex. Tapping apex. I will only use the word tapping apex if I'm suspecting a loud first start sound and I'm suspecting mitral stenosis. Otherwise, I will not use the word tapping apex. And the last is a normal apex. If you read about normal apex, it is described as tapping. But for examination point of view, I will never use the word tapping unless I'm ready to say loud first start sound and I'm making a diagnosis of mitral stenosis. Okay? Parasternal heave. What does that tell you? You told me there's a parasternal heave. What does that indicate to you?
Parasternal heave is it to increased blood coming to the left like it is dilation of left side of heart, sir, due to that.
Okay. Now remember, if you remember your anatomy, the precordium, the left ventricle is lateral. So you will get a apex down and out, and you will get a forceful apex or a heaving apex. That indicates left ventricular hypertrophy. Right ventricular hypertrophy typically will have parasternal bulge, parasternal heave. So when you tell me there is a parasternal bulge or parasternal heave, in my mind, I am beginning to suspect a right ventricular hypertrophy. The apex down and out, which is lifting my finger, forceful or heaving, I'm suspecting left ventricular hypertrophy. Okay? So you have told me apex down and out, parasternal heave. According to me, I have got features of biventricular hypertrophy. Do you understand, Anjali?
Yes, sir.
Why did you not grade the diastolic murmur?
It was soft or grade 1.
Why did you not grade? You graded systolic murmur. Why did you not grade diastolic murmur? So I am happy you have not graded it. Systolic murmurs should be graded because if they are 3, especially 4 plus, they are likely to be organic lesions. All diastolic murmurs are considered organic due to an organic pathology. Therefore, we do not need to grade diastolic murmurs. When you examine the chest in the respiratory system, I'm surprised for the last 7 months, this child has been breathing fast, suck-rest-suck cycle. I'm surprised that there was no prominent rachitic rosary costochondritis like prominence. So you need to go back and see the baby again. Severe malnutrition, respiratory distress going on for many months. Please check. There is a possibility there is costochondral junction prominence and an abnormal chest. Have a look at that.
Yes.
On abdomen, you should specifically tell me liver not palpable. Again, I have a serious doubt that the liver may be palpable because your rate is very high.
Yes.
How many hearts do you have, Anjali?
How many hearts, sir?
Yes.
1 only, sir.
Rubbish. There is a left heart and a right heart. So what are the features of left heart failure? What are the symptoms of left heart failure?
Left heart failure, ascites, then increased liver size, and pedal edema, and
Okay, so remember, there are two hearts. Anatomy was wrong. There are two hearts, left heart, right heart. If the left heart is failing, you will get dyspnea, dyspnea, dyspnea. The first dyspnea is exertional progressive dyspnea, suck, rest, suck cycle. The second dyspnea is orthopnea, lying down, older child. The third dyspnea is paroxysmal nocturnal dyspnea. When you get history of exertional progressive dyspnea, with or without orthopnea, with or without paroxysmal nocturnal dyspnea, immediately you are thinking of left heart failure. Understood?
Yes, sir.
On examination, there will be tachycardia and gallop. There will be tachypnea with distress, and there will be an apex down and out showing cardiomegaly. The other heart failure is called the right heart failure. The right heart failure will cause bilateral pitting pedal edema or sacral edema. It will cause enlargement, tender enlargement of the liver, therefore right hypochondriac pain in older children, and it will cause raised JVP. So when my child has got bilateral pitting pedal edema, sacral edema, with a tender enlarged liver, elevated JVP in older children, I will suspect right ventricular failure. Do you understand?
Yes.
So getting that history is important because you can then decide which ventricle is failing. Is it left or is it right or is it both? However, in infant less than 1 year, suck rest suck cycle due to feeding difficulties is difficult to classify, but more likely to be left heart failure, dyspnea, dyspnea, dyspnea. Sweating excessively, diaphoresis, sweating excessively is also a feature of heart failure due to increased sympathetic compensatory mechanism, and failure to thrive is classically seen in heart failure. If I had a liver, I would have been very interested to look for evidence of right heart failure. Are we clear?
Yes,
So
sir.
always ask for left heart, right heart, and of course, young infants is slightly different. Okay. So no doubt, this child you've correctly diagnosed as a. So there are 5 questions you must answer in a child. At least 5 questions.
Yes.
First decision is the cough and the respiratory distress due to heart or respiratory? First question, heart or respiratory?
So, due to heart or respiratory, we will distinguish based upon the duration of symptom. Here, the child is having recurrent respiratory disease, and cardiac causes are mostly associated with recurrent respiratory infection. And if we take and on auscultation, and also we are getting murmurs.
You know, don't come to the murmur. See, I'm telling you to think of the diagnosis even before you come to auscultation. So first question you must ask yourself during the history and examination is it a heart problem or a respiratory problem? Second question, if it is heart problem, is it congenital or acquired? Give me example of acquired heart problem.
Infective endocarditis.
Yes.
Then
Rheumatic fever, acute rheumatic fever, viral myocarditis, and nowadays Kawasaki disease. Okay. So in this case, you are more likely to consider to be a congenital heart disease, correct? So second question is, if it is heart disease, is it congenital or acquired? Third question. Good. Third question. If it is congenital, do you think it's cyanotic or acyanotic?
Acyanotic, sir.
Very good, because you took the history and you examined. If it is acyanotic, the fourth question you must ask, is there a shunt or no shunt?
Shunt.
What do you think? Why do you say there's a shunt?
Sir, recurrent respiratory infection is
very good, due to left to right shunts, agreed. With increased flow into the lungs.
Increased flow, engorgement will be there, that will constrict the bronchus, and also hyperemia will be there, so mucus will be more. So nidus for infection and recurrent bronchopneumonia.
What is the examination feature in favor of shunt?
In favor of pan systolic
Pan-systolic murmur, grade.
Grade 4.
That is also very important because you felt a thrill.
Hmm.
Okay. So first question is heart or respiratory. Second question is congenital or acquired. If it is congenital, is it acyanotic or cyanotic? If it is acyanotic, is there shunt or no shunt? Usually the shunt in acyanotic is left to right. After you ask those 4 questions, what is the common differential diagnosis of shunt, acyanotic congenital heart disease? What are the 3 conditions you and I can diagnose clinically?
Ventricular, sir, based upon pulse, we can diagnose, what was that? Abnormal connection between pulmonary. We like based upon if the pulse is hyperdynamic, the
No, first
condition
tell
will
me
be
the 3 common shunt acyanotic congenital heart disease. 1, 2, 3.
ventricular septal defect,
Very good.
then atrial septal defect,
Very good.
then total anomalous pulmonary venous connections.
Boo,
And
boo,
then
boo, boo, boo. Don't give me 500. PDA.
patent ductal heart disease. That's why I
Okay.
was not remembering.
So for you and for me, Anjali, we as clinicians can only diagnose VST, AST, PDA. So you must know everything about VST, AST, PDA. Which in VST, AST, PDA, who goes into heart failure?
BST and PDA usually goes for heart failure. Sir, AST is
Very
really
good.
compensated.
Very good. Now, if you look at your diagnosis, you have not said heart failure. Look at your slide diagnosis.
Increased pulse. We have to write here associated with heart failure.
Yeah, because I have to treat heart failure. Okay. So remember, is it heart disease or respiratory disease? If it is heart disease, is it congenital or acquired? If it is congenital, is it acyanotic or cyanotic? If it is acyanotic, is it with a left to right shunt or no shunt? If it is a shunt, left to right shunt, acyanotic congenital heart disease, is it a VST? Is it an AST? Is it a PDA? Among them, you and I know that VST and PDA will have heart failure. ASD, less likely to have heart failure. Okay? Now, 2 other things missing in your diagnosis is heart failure. Number 2, you never mention whether it's in sinus rhythm.
Yes.
And you never mention whether there's pulmonary arterial hypertension. You did write increased pulmonary blood flow, but maybe if the loud second heart sound was present, if it's palpable P2, you could have said pulmonary hypertension. So never forget to tell me heart failure, rhythm, and whether there is pulmonary hypertension. Okay?
Yes.
Any question you have or you want to present a little more?
Sir, I had investigations report attached, echo report and
what
echo and
investigations would you do?
X-ray report and echo report was there.
Okay,
so
tell
I
me.
attached that.
Tell
So
me
this
about...
is the reference X-ray that I have taken from the net. So here cardiomegaly and increased pulmonary.
How do you know there's cardiomegaly?
So this AP transfer as AP and transfer ratio we calculated this from that.
How do you measure? So you take the center line, okay? Draw a line vertically in the center. To the right hand side, take the largest measurement of the right heart to the perpendicular to the central line. You then take the largest measurement from the left heart, end of the left heart to the central line. These 2 together divided by the intra-thoracic diameter at the level of the right diaphragm, that should be more than 50% to call it cardiomegaly. A plus B divided by C. A is the largest measurement from the center, right side, largest measurement of the left border from the center, both added together, entire thing divided by intrathoracic diameter. Second thing important is to look at the lung field. Can you see vascular markings in the lung field?
Yes.
In the middle zone, going even to the periphery. That indicates increased pulmonary flow.
Yes.
Okay. Next slide.
So this is the echo report. Shall I read out, sir?
Okay, so basically your child has got a large perimembranous VSD, correct?
Yes, sir.
I'm happy if an undergraduate makes a diagnosis of a acyanotic congenital heart disease, probably a ventricular septal defect, large. Why do you think clinically it was large?
Due to like the recurrent respiratory infection only, sir. If it is small, usually it is asymptomatic. Upon auscultation, we get to know. If it is moderate, its severity will be less, sir. Based upon that. And the pansystolic murmur was harsh, grade 4.
Are you saying a large VSD will have a very loud murmur?
Large VST is not usually associated with murmur, sir, but the severity of the disease was high. So I thought
Severity of what? Of the heart failure.
severity of heart.
Okay, so this baby, according to your history, went into heart failure quite early. Over the last 7 months, there has been heart failure. What is Rogers disease? What is Rogers disease?
Rogers disease. I have to read on this.
Okay, so Rogers disease is your homework. Unusual thing, but very commonly asked. It's good to know Rogers disease. Okay.
I'll read on this.
And Rogers murmur, and therefore, what is Rogers disease? What is palivizumab? P-A-L-I-V-I-Z-U-M-A-B. P-A-L-I-Z-U, sorry, P-A-L-I-V-I-Z-U-M-A-B. So that's your second homework. Okay. Third is, when do you call, what size will you call a small, a large, or a moderately enlarged VSD?
Less than 0.5 centimeter or less than 1/3 of the outtake area, and moderate is 0.5 to 1 centimeter square, and large is more than 1 centimeter.
Okay. What is the significance of the bundle of His? HIS, bundle of His. You remember your physiology?
Yes, sir.
What is the significance of bundle of His in relationship to VSD?
Bundle of this, if it is also, like it can be associated with arrhythmia. I'm not sure, sir.
Okay, so that's your homework. How would you treat this child? What are the drugs, pharmacological treatment of this child?
Sir, here as the congestive cardiac failure is there and associated with increased pulmonary hypertension also. So we will treat, first of all, we will do symptomatic management of respiratory infection. So for symptomatic management of respiratory infection, we have to give mucolytic agents, antibiotics along with physiotherapy. So first we have to treat the respiratory infection. After that, we have to take care of the pulmonary hypertension associated. So for treating pulmonary hypertension, we can give AC inhibitors like enalapril, and then after that we have to we have to instruct the mother, like here as severe acute malnutrition is there, we have to manage that also. For that we have to instruct the mother to feed the baby, to first of all to prevent infections, because here the most common cause what I am getting for malnutrition is recurrent respiratory infections. So we have to prevent the infections, and then we have to tell the mother to, even if we have to wake up the child and from sleep and feed, and other supplementary feeds also can be given, sir. And then we have, after everything is corrected, we have to post for correction of ventricular septal defect surgically.
Anjali, I want you to reorganize your thought. When I ask you the treatment, you have got an acyanotic congenital heart disease, left to right shunt, in heart failure. That is your primary problem you're dealing with now.
Hmm.
Incidentally, you have put you're labeling it as a pneumonia, as a lower respiratory tract infection. I'm not convinced about the lower respiratory tract infection because the fast breathing can be due to heart failure. Third, there is SAM. Fourth, you did not tell me there is anemia.
Anemia.
You did not add it to your diagnosis. Okay? And fourth, you did not tell me. Fifth, you did not tell me missed immunization. Okay, so I'm going to minus points for immunization and anemia being such a common problem. So I would say these are the 5 problems, and I would start with heart failure. And I'm waiting to hear diuretics.
Diuretics to decrease
I'm
the
waiting
workload
to
on
then
heart.
hear ACI inhibitors, and then I'm okay with digoxin in some cases. But diuretics are important in heart failure. Number 1. Number 2, pneumonia or lower respiratory tract infection in a child who's got a heart disease could be viral or bacterial. According to IMNCI, what mucolytic is advised? According to IMNCI, what mucolytic is advised?
Sorry.
No mucolytic. Don't tell me all these funny things. Okay. So remember, read up on IMNCI. It is very rational. All this mucolytic expectoration doesn't do anything, especially dangerous in children less than 6 months. All these cough mixtures are tamasha. So nose cleaning with saline nasal drop, fast breathing, lower respiratory tract infection with tachypnea, give a simple antibiotic. Injectable if severe pneumonia, oral if pneumonia. Okay? And I won't go into SAM, anemia, and immunization. I think your time is up. Is there any specific question you have for me? And I hope you gained a little bit.
Yes. Thank you so much, sir, for sharing so much knowledge.
My pleasure, Anjali. Very good presentation. Very positive and very confident presentation, but little organization of the treatment. And also just take a few tips away of what I tried to mention to you. The aim of history and examination is to make a diagnosis.
Yes.
Okay, so focus on that. It's not meant for you to be just completing A to Z, top to bottom, okay, head to toe. Idea is to crack a diagnosis.
So I had a doubt also.
Yes, please.
So chief's complaints, even I was confused regarding it. Like some professors prefer, like they tell what was the complaint but for which the child came to the hospital, that you should write. But so here in this case, the child came because the child was having hurried breathing and cough. So I thought like that. So that's like for that only I wrote like that. But some professors tell you should write from starting what and all the chief complaints are there. So exactly what to do in this case scenario.
So I don't have an answer. If I'm your examiner, please remember what I told you. If somebody else examiner, so that is the difficult part.
Yes,
now,
so every
both
examiner
of them are right. So what I'm telling you is, remember I told you presenting complaint, and the next thing is history of presenting complaint. Your opening statement of history of presenting complaint should be, the child was apparently well till. That decides what you can put in presenting complaint. And I don't think anybody will attack you. For example, my child comes to you presenting, a 4-year-old boy presents with swelling of the body, periorbital edema and swelling of the body since the past 3 days, with decreased urine output since 3 days. What is your diagnosis, doctor?
Nephrotic syndrome.
Can it be glomerulonephritis? Periorbital puffiness, swelling of the body, decreased urine output. Presenting complaint.
It is renal pathology, we can find out for further elaboration.
Can it be still glomerulonephritis? 3-day history, periorbital puffiness and swelling of the body with decreased urine output. Can it be nephrotic? Can it be glomerulonephritis? Can it be one of the two?
It can be nephrotic, sir. About
Agreed.
glomerulonephritis, I'm not sure.
Okay. Now, can you imagine if I've had 6 episodes in the past? Can you imagine if I said presenting complaint, a 5-year-old child male child presents with recurrent episodes of puffiness of the eyes and body associated with decreased urine output, 5 episodes in the past 3 years. Present episode 3 days. You saw what I did.
Yes, sir, like from start.
But I used the word. So you could have said suppress, difficult feeding, failure to thrive, murmur in the immediate newborn period at 1 month. Presently, since the past 7 months, failure to thrive. Since now, for 3 days, fever, cough, fast breathing. I can make that my presenting complaint to satisfy both parties.
Yes.
So you got to use. Now, don't tell me hit by lorry 10 years ago. Now he's got tooth pain. Presenting complaint is tooth pain. Don't put a lorry accident or he got, he had scabies when he was 2 years old. Be logical in what you're presenting. History of presenting complaint. Child was apparently well so many days ago or so many weeks ago, so many months ago. In this child, I don't see why you can't say this child has had problems since 1 month of life. Present now since 3 days has come with fever, cold, cough, fast breathing. Sorry for confusing.
Yes. I got an idea now. I'll correct everything and
you try it out in the presentation next time.
Yes. Sure.
Over.
Thank you.
Thank you, Anjali.
Thank you so much, sir. It was indeed a very comprehensive class, actually. The discussion was very useful for us. And thank you so much for teaching and guiding us, sir. We are ever grateful to you and need your blessings and support throughout, sir. It was a great effort by the presenter. We could learn a lot because of your well-prepared presentation. Thank you, Ms. Anjali. So I also thank all of them who have joined via Zoom and YouTube. Thank you, everyone. Goodbye.
Once again, thank you, sir.
Thank you, Anjali. Bye.
Yes, sir.
Good night. Have a good Diwali.